good morning still, isn't it? Feels a bit later. Right, so I'm going to be talking about curriculum, which is a topic I think that people often phase over and think, oh, you know, what's in it for me? So in this session, we're looking at the ACRRM curriculum is under review at the moment, really in the planning stage. But what we're focusing on particularly is usability of the curriculum for different groups. So what sort of documents do we need? What interpretation will be helpful? So you can see we're going to look at some of the feedback we've had to date. We're going to review the context that the curriculum review is taking place in, timelines, proposed changes, and importantly, your sort of feedback on some of these proposals and what other things do we need to do. So who are the users of the curriculum? It's really quite broad. Registrars are obviously key users. I'm not sure how many registrars in the audience here today? Few. Have you read the curriculum? Yes? Good, excellent. Educators use the curriculum a lot because they're the ones implementing the curriculum. Assessment writers, that's probably where I've got quite a bit of feedback from really, because they really dissect the curriculum and use it in the assessment as we've been hearing today. Assessors obviously need to be across the curriculum. Supervisors, I think you're an important group, but I think it's probably hard for supervisors to use the curriculum at the moment, but let's find out about that. Fellows, ideally the curriculum is for fellows as well. Credentialing committees, trying to understand what a FACRRM can do, especially if they have advanced skills. Employers, medical boards, and the list can go on. So I've asked who are registrars here, who are educators here, medical educators? So quite a few. Assessment writers, we've got some down here. Okay, some assessment writers. Assessors, probably the same sort of groups, yeah. Supervisors, we've got a few supervisors. It'll be interesting to hear your feedback. Probably a lot of fellows. Credentialing committees, anyone here sit on credentialing committees? John, yeah, excellent. Employers, we're probably all employers and medical boards. Okay, so let's go on. So I think when you ask for feedback on a curriculum, often you'll get the detail of the things that are, you know, we don't do that anymore, or this needs to be updated or something. But what I've been hearing is that we really need to have a really clear and concise picture of what a FACRRM is and what it does, what we're trying to create here. And I'm not sure that our documents are clear enough yet on that. I think the other thing, the feedback I've heard over the years is it's such a broad scope of practice, but what level of skills do you want in those things? What's common? What do you spend most of your time doing, and what do you need to do for rarer cases? For the educators and for the registrars to know what can you expect to be taught when you're going through training? What do you need to go out there and learn yourself, maybe on the job or doing your own reading, how it's assessed, so you can understand more about what the focus is. The last one, all of the curriculum and most of our documents actually are written as what you need at fellowship. But we really don't at this stage have anything to say how you might progress to get there. So if you are a supervisor and you have a registrar who's in second year of training, what would that look like? What would you be expecting? So those are some of the questions or some of the areas that I've heard and the college has heard feedback on that we need some more information. We're working in a time of huge changes at the moment, as you know. We're moving to transition to college-led training, the National Rural Generalist Program, professional performance framework for fellows, hospital credentialing trends, that seems to be changing by the day. I keep hearing things. And of course, there's a lot of future technologies coming in. So those are some of the things that we're trying to think about as we go through the review. really this was me wanting to share some photos of my recent sail to New Caledonia, but it was thinking, you know, we've got some really positive things happening and some great things going on, but there's always change over the horizon, and you've got to be prepared for anything, really. So in terms of all those things going on, our timeline for this review, we decided we'd use this year for sort of planning, trying to understand what we needed to do. Next year, once we have a more consolidated picture of it, we'll come out and consult with you all, and then we'll be aiming to implement in 2020. So probably just to say, the things that have been talked about, obviously there'll need to be some refinement and updating of the curriculum, but I've not heard anyone say we really need to change the scope of the curriculum. So we're not talking about anything that's major in the way of changing what's in the curriculum. It's more looking at how it's presented. And before I go on, I also should say that the things that I'm discussing are proposed. They haven't been approved by the college board. They're really for discussion at this stage to see if they will be useful. So one of the things we're working on is maybe we need some different types of documents for different audiences. Maybe so a more concise document rather than the curriculum. I think is probably about 150 or so pages at the moment. But you know, maybe something a little shorter that people can pick up. Maybe doctors who are thinking about training. You know, what would it be like? What should I be able to do? For credentialing committees, that might be useful. And then maybe something that's even more detailed than we've got now, which would be good for the medical educators and for the registrars as they move through different areas. And then possibly something about prescribing progression. So this is the, and I've avoided using terms for what these documents might be called, because every time you use a term, people have a picture of what that means. So I'm just calling them documents at the moment. But a document that has clear aims, principles for what we're trying to achieve, and high-level abilities for domains, core topics, and advanced. I'll give you some examples of what I mean here. So at the moment, we don't have a clear definition in our curriculum of what type of doctor we're trying to produce. But ACRRM signs up to the Cairns Consensus Statement, so it's quite possible that that would be a really good and clear statement to put in the curriculum. I know there are other descriptions around, so as I say, it'll be up to the board to decide, but having, I think that sets out a really clear description of what we're trying to achieve. At the moment in the curriculum, there are generic ability statements across the domains of practice. So the proposal would be continuing with those. So these are some examples from the current curriculum. So as you will know, there's the different domains, what is required in community primary care, hospital care, emergency care. So high-level ability statements. So remember, this is the overarching sort of document. And then possibly in that same document having high-level ability statements for the topic areas. So anaesthetics, for example, for all fellows, what would you expect in anaesthetics? And it's not giving a general anaesthetics, obviously. So maybe in this short document, having a description at a high level what you would expect for all FACRMs and then those who went on to advance their skills in this area. So these are just examples. So that is the thought around. So I've already drafted what this document might look like. I think it would be about 25 pages. So something, as I say, that should give a pretty clear, concise picture. So I might just stop and ask for feedback. Would that be useful? Is that something that you would find helpful? Somebody got the microphone? Jolene? Oh, sorry. I've got questions in the middle here just to confuse you. Thanks.
hence asking about the guidelines. I'm just trawling through the curriculum now, and it is very challenging.
Yeah.
There's a lot of talk about domains. Really? Okay, sorry, I didn't want to shout too loudly. I'm trawling through the curriculum now, and it's very, very confusing. There's a lot of talk about domains, but actually knowing what we need to know to compare it to ASIM, and it sounds like that's what you're doing. Their curriculum is a little bit easier to read because they will have, expert level that you have to know, and then sort of good to know general stuff that is good to know, but not necessarily mandated for the exams. And then, people who get excited want to read the fine print. So it'd be brilliant if we could have something similar, and then it gives you focus for study for the exams, which are in March, which I'm worrying about. Yeah. Next.
Anyone else want to make any comments? Maybe supervisors or credentialing committee input?
As an educator who looks after supervisors as well, this type of document would be, that was a bit briefer, would be something that would be very useful to use for supervisors, because at the moment they don't engage with a larger document, and particularly that idea of knowing about where your person should be up to, where your registrar or candidate should be up to at a particular time, helps them to give better feedback in terms of a supervisor report.
Okay.
Can I just clarify what you meant with the advanced parts, like for instance the anaesthetic slide you just put up before? Are you saying that for the AST, someone that does an anaesthetic AST will be able to meet those curriculums, or is that just an advanced part of the primary curriculum that they would be expected to do, and why separate them if that's the case?
So this is in the high-level document. It would be describing what all fellows need for anaesthetics, but then saying if you want to have additional skills, from terminology this morning, or advance your skills in anaesthetics, then you would be able to do these things. So on the right-hand side, this is essentially the JCCA. But there would be detailed documents still, obviously, about these, but it's just trying to get a clear picture, because often you think, well, rural doctors need to be able to do everything. Well, at what level? And so it's one document trying to do all of those. So all of the advanced skills would have, 5 or 6 high-level abilities that would give you an idea. If you advance, then this is what I'd be able to do.
And Lynn, as a supervisor, I think I'll probably expand on that a little bit. You'd already mentioned that one of the concise editions of these, and I'll be interested to be part of the consultation next year. So all of these user groups we've identified are people who are already engaged in the college process. You're absolutely right to identify potential registrars, so junior doctors, PHY 1, 2, as being people who need to be able to comprehend the curriculum. But the other group that you're going to need a lot of over the next 5 to 6 years is supervisors, particularly supervisors in primary care, because they look at the current curriculum and it is trying to be all things to all people. So potential supervisors would look at that and say, there's no way I can deliver that. I'm not an ACRM supervisor. Best leave that to somebody else. You really need something that does adequately cover the breadth of primary care that we're wanting to encompass, so that GPs are feeling empowered to actually be part of the journey with you.
Okay. Might come back at the end a bit more to supervisors, because I think that is the group that it's really hard to understand what will be useful, and so we might come back to that. And then, of course, all these documents are not purely curriculum, there are other things. So that was a description of possibly what could be in the high-level document. But for those who are using the curriculum to design medical education, registrars who are trying to understand what they're going to be taught, what they need to learn, how they're going to get there, proposing probably more detail than what we've got at the moment. So this is, I just stuck with the anaesthetics theme because it was there. So remember, these are all just examples and very draft at this stage. But taking those higher level abilities down to more learning outcomes. What do you need to know? What do you need to be able to do? And then how much you learn it. So the learning column is a bit difficult because obviously we've got training organisations who deliver the curriculum. We've got the independent pathway we delivered ourselves, but when you're a medical educator and you're trying to work out what do I actually need to put in my program as opposed to what might a registrar learn in practice or expected to go away and find themselves. So something that might describe that, so not saying you must put this in a workshop, but thinking that this would be a core stuff that, we do expect you to deliver as a medical educator or as a registrar you expect to learn. So something that starts to help to tease out, when and how you might get there. And then the next column is how these things are assessed. So that's, and across the domains, which I think may help supervisors as well if they just picked up the piece. If it was a registrar coming to a hospital doing hospital inpatient part of training, well, what do they need to get while they're there around anaesthetics? So I think there may be some applicability to when I'm in this particular type of environment. What am I trying to pick up while I'm here? So this is not too different to the current topic areas, but a little bit different. And then also trying to see where you might focus your attention. I think the feedback we get is at the moment it's everything in the curriculum seems to have an equal level of importance, but yet some things you must deal with every day and some things you only see occasionally. So thinking about some of the evidence about what are the common presentations. So this is just an example, obviously based on beach data as to what's common. So we thought if we did this, and I know in training organisations, those are some of the things that you focus all your education on in the early days, because those are things you need to know about. So we thought if we did that for community primary care, what do you expect to see when you're doing hospitals in rural areas? What emergency presentations? It might also help to focus on, where do you need to put your most effort, especially in the early time of training. I might just, I'll stop there. So that's the more, potentially, what the more detailed learning unit or however you might describe it. So those would align to the topics at the moment, so anaesthetics, paediatrics, etc., that there'd be something more detailed on each of those. So I might just see, I'm not sure if that was able to give you much of an impression of what that might look like, but what's your immediate thoughts on that as being helpful or not helpful? Thumbs up. Yeah, I think it's a bit difficult. Charles?
Yeah, I was just going to remark that at some point the detailed information does need to be available to look at. Not everybody will necessarily read all of it, but certainly as an exam writer, it's very useful to have that for somebody navigating their way through education and wondering what the hell. That sort of detail probably is needed at some point. Looking at the question of domains and topic numbers that were apparent there, I'm wondering if lead-in segment on the main detailed document might include a how to use this document guide, a bit like some textbooks have, how to get the best out of this textbook or
Absolutely.
how to look at these guidelines.
Yeah. I mean, obviously, a lot of this has been drafted as documents, but remembering it's all proposed at this stage, so nothing is signed off. So I was just trying to give you captions, but absolutely. Dale?
Yeah, I had two thoughts, and I think this is really a positive step in the right direction. I think the idea of the layers of knowledge is important because I think it's like building blocks in education. You sort of get foundational knowledge, and then you build on that, and then you build on that. And I thought that was an interesting aspect of the CanMeds, where they talk about foundational knowledge, and then you build on it. The other thing is when I did my master clinical education, they made a big distinction between the sort of syllabus and the the curriculum.
Yeah.
And, you know, the syllabus is the list of topics, and then the curriculum is something bigger than that, which is, you know, where you want to get to. And, you know, the thing I've been really thinking a lot about is the importance of context to, you know, in some ways there's content knowledge that might be similar to emergency medicine, but in some ways, in terms of the content knowledge, but the application is really different in the College of Rural and Remote Medicine because of the nature. So the context is important, and how do you build the context into the curriculum of, you know, where this gets delivered and how it gets delivered to achieve the fellow that you want. A thought that's really exercising my mind, and, you know, how do you write that into the curriculum too is another layer of challenge.
But I suppose the domains do that to a certain extent. I suppose maybe that's more in the delivery of the curriculum, the experiences, the...
So maybe that's the documents, those documents might articulate.
Yeah, I think, you know, ultimately you need to have something that they all fit together to, you know, give the same picture but have different applications. And the terminology, curriculum, syllabus, that's why I took out terminology, because I thought I'd just call them documents, because I don't get too focused on terminology, but some people do, and then you have an impression of what this thing is. So I don't know what these documents should be called, but they, you know, I suppose at the moment are they going to be useful? So maybe we might go on to the progression one, because to be honest, oh, sorry, another comment, question?
Yes.
Sorry.
I'm a non-ACRM supervisor.
Yes.
And in these documents, I'd find it really helpful if in your brief outline of the curriculum, you had link buttons through to the more detailed curriculum.
Yeah.
And if in the detailed curriculum, you had a search button that you could put in a bit, you know, nausea or whatever, and then you'll get where we're supposed to be, the three places I'm meant to look. And then if you also had a developmental milestones picture graph of where my registrar is supposed to be along that curriculum with links, that would be really helpful
With links.
for us to just dip in and out.
Yeah, definitely all very possible. The last one about progression, let's explore that one more. So, oh, sorry, I've gone the wrong way. So, at the moment, as I say, there isn't anything that describes what a registrar looks like as they progress, or for a registrar to understand sort of how they are progressing towards that end point. And at the moment, it's the area I've had the least sort of feedback on, I guess. To me, it sounds like it would be very useful. Somebody's got a question up the back. Oh, sorry. Maxine.
And RACGP has a lovely one that you could just...
On progression? Do they?
Yeah, they've got this lovely picture, and it's like the developmental milestones, and you can see where your registrar's meant to be.
Okay. I haven't seen that one. Yes, I've seen some of the RTOs have got some good stuff in that area. So there's work, oh sorry, better have the question at the back. Yeah.
Lynn Bronwyn-Carson, and speaking as an educator, and I've written stuff like this, you know, is aware of the skill, has, you know, emerging evidence of the skill, has acquired the skill. And what I find as an educator is we tend to glaze over, you know, and we go, oh yeah, where are they again, you know, whereas I'd encourage you a much harder and, you know, more tedious process, say in the example you've chosen here, is, you know, has awareness of developmental milestones and can name appropriate age of stage. And then in the second one, that you say perhaps routinely brings in knowledge of the development milestones into a paediatric consultation in a meaningful way. And then in the third one, taking the rural context into account, routinely uses milestones in their consultation and is able to refer appropriately when recognising, you know, problems in the whatever. You know, so it's actually much harder to write because the others, you know, knows, emerging and competent are much easier to write, and it will take you much longer. But when a supervisor rings us from somewhere and says, do you think this registrar is operating at the appropriate level for a term 2 registrar, we can look at the curriculum and then be able to answer in a meaningful way. We'll say, well, they should be doing this. And so it actually would be far more helpful.
Yeah, okay. So that essentially is what I thought might be useful. As I say, this work hasn't been developed at all yet, but so I've been looking at work that's being done in Canada, which is called Milestones, and there's quite a few different ways these things have been presented, novice to expert and various things. As you say, CanMeds. Okay, so I'm hearing that you think it would be really useful, and that's the main thing that I wanted to hear. So I suppose the next question is, what level of granularity do you need around this? Because you could write progression for every high-level ability statement. You could do one maybe for, no, I don't know. It's how much detail. I wondered if for each of our domains, whether we had 3 sort of things for each domain. So a summary, so community primary care, hospital care, emergency care, sort of what would you expect? Is that the sort of the level of detail you'd be thinking of? A few more than 5 per sort of domain?
That question really is driven by your assessment committee.
Yeah.
The curriculum to reflect what is going to be included in the assessment and vice versa. So you don't want the curriculum to go right out here if assessment only wants to be down here.
RT, do you want to make a comment on that?
Yeah, sorry, Conrad, I was just thinking else while you're talking, but I think the curriculum, the assessment is actually secondary to the curriculum. The curriculum defines what's expected and what should be known, and then the assessment should assess that. You know, and I think if you're asking me what I want to assess and then design a curriculum, it may either be limiting or too over-encompassing. I really think we ought to decide as a college this is what the curriculum should look like, or syllabus, or whatever, but these are our standards. And then my job would be to assess based on that, as opposed to the other way around.
But I think the assessment does go down to quite a fine level of, you know, anything in the curriculum essentially can be assessed, whereas if you're trying to give a gauge for a supervisor, you know, I assume we're not going to want to go down to quite that level of detail. Okay, so this, as I say, this work hasn't been developed at all, but that's sort of what I was thinking. So I'll come to the question in a minute. That maybe, I suppose the next thing is how many levels do we need? I've seen sometimes 4 or 5 levels. I wondered if maybe level 1 could be at the end of core clinical training, you know, often where you first see the registrars, what you might expect someone to be like then. Maybe sort of midpoint in primary, rural and remote training, and then fellowship. I mean, essentially the curriculum does define the fellowship end. Because we have ASTs as well, it becomes a little bit more complex, but so I'll just take the comment here, and then I might ask about how many levels people think might be helpful.
I was just sort of thinking, and when you were asking about the granularity of what we need, when somebody's progressing as expected, you don't need heaps of detail. But when there's a problem, you kind of need enough detail to tease out where the problem is.
So a bit more of like a diagnostic type.
That's right. So it's almost at a 2-stage thing. So yeah, just it popped into my head.
So you might need a high level one of those two that you just say,
Yeah.
oh yeah, look, this looks good, but if you have a problem, drill into a
Yeah,
more,
so you
more
want enough
detail.
capacity for a supervisor or educator to be able to drill down a little bit, but you don't actually need that level on a day-to-day routine basis.
That's better, for me anyway. Okay, so so that was about level of detail. So yeah, I suppose for a registrar that's not progressing as you, you know, would hope, the sort of the one that's needing some remediation or additional learning, then it probably does become a bit more detailed, doesn't it? Okay. What about how many levels do you think we should describe? Remember, someone's got to do all this work, and I'm going to ask for volunteers, surely. Yeah.
And I like your division of 3, so I think sort of when they start sort of end of PRT to maybe even fellowship level, it just makes sense. Very
Yeah.
clear.
And your ASTs are completely separate, on a separate curriculum anyway, and so you need to consider that this is
Yeah. But you can't sort of say year 3, because sometimes year 3 is an AST year or something, so yeah.
you should be looking at post-CCT, mid-PRT, and end of training.
Okay. Any alternative views on that?
When you do your mini-sex visits, though, you're asked to assess on a standard of what they should be at the end of their training.
The formative mini-CXs? Anyone want to make a comment on that? I suppose ultimately they came out of the summative mini-CXs, which was fellowship standard. But I suppose, I don't know. Anyone want to comment on the mini-CXs? It's a good question. I haven't really thought about it.
But you're assessing for the end of training, and then you've got this other level where he's all right for now, but he's not all right for the end of training. What are you doing?
Yeah.
I think this would actually make mini CEXs easier to do because you're not feeling as though that you're saying inadequate or extraordinary, you're just acknowledging at which point they're actually at. So I'd
For their level of training, yeah. Yeah, so, yep, okay. I think that's where these things come into, as the formative assessments as they go along. So that's where I saw them really being applied, yeah.
I don't know if you come across the idea of progressive marking, where there are some medical schools that everybody sits the same exam.
Ah, yeah. Yeah.
And the idea is, and you don't expect the first year student to get the same mark as the final year student, but it's sort of, because it's progressive marking, it's sort of making clear to everybody where they're going.
Yeah.
So, you know, I think that's a bit of an interesting idea that, you know, the marking's not, are you competent or not, but, you know, how much, like the trust sort of idea of, you know, what level of responsibility is this trainee up to and how are they travelling in terms of, well, where do they need to be if they're going to have their fellowship in 12 months or whatever. So that's, progressive marking might be an idea that's, or could be useful
Yeah,
to try and tackle that,
that
because it's a difficult topic, yeah.
Just taking you to your topic, because you sort of started to make some comment about EPAs, really, weren't you? The marking scale of EPAs. Has anyone here ever used the concept of EPA marking in a mini CX? Could you change your mini CX scale to how far away, you know, I would need to be when this consultation was taking place? That the idea of trust. Dale, you probably can describe it far better than myself, but I've often wondered, could you use that in mini CXs or case-based discussions even?
I'm holding the microphone and I would say yes.
You say yes. Actually, we could hardly hear you, but I got that you said yes. Dale, I know
I think it is possible if you wanted to do that, and I think it's actually a good flag. And in some ways, what I think is a bit attractive about that idea is that's how, as supervisors, we think. You know, we think in terms of how much responsibility will I allow that trainee to do, because we make that decision day to day. So what's attractive about this is it's sort of, it's called construct alignment, it's a big thick word, but you know, the testing strategy is sort of similar to how supervisors think anyway. So I think it is possible if you wanted to do it, and it could be useful.
Has anyone seen anyone use that technique on other assessments other than EPAs, that marking scale?
Yeah, I had a crack, but nobody listened to me because in intern space it was just overrun by the AMC assessment, so that you know, that's what we all had to do and salute.
But that was on EPAs as opposed to like a mini CX, wasn't it?
I've had a crack at using mini CX with the same sort of anchor.
Okay.
Don't know whether it's any good or not, but
Yeah.
I'll try and find it and send it to you.
Okay,
Have a
thanks,
look.
Dale. All right, so we've strayed a bit. So it sounds like, well, what I'm hearing, everybody seems to think it would be useful to have something about progression. Somewhere around, well, possibly 4 or 5 high-level ones for each domain, but maybe more detail when you need to really look in detail for an individual. And most people seem to think 3 levels sounded about right. Okay, cool. Is there any more comments on those topics? Because then I'm going to open up to what else do we need? What other questions are not answered by our documents at the moment? What other tools or... So it can be further comments on what we've discussed, or it can be other things. Maybe registrars, what else do you think we need in terms of tools or documents that help you to understand what's required? Medical educators, any other thoughts? Or have I covered them all? Yeah. Ah. Yeah. And you know what's in a pre-anaesthetic test, so you don't need to be told. And we might. Yeah. No. So, would it be useful for supervisors to have a supervisor report that links more directly to what's in the curriculum? So, if you're in a hospital and you've got an ACRIM registrar coming, maybe to a general medical ward, or what are the things that we're expecting them to gain, and therefore in the supervisor report at a high level, done a pre-anaesthetics check, or would that be, so you don't have to pull out the curriculum, something that just applies it to your situation? Well, how is it easiest for you to interact with? You've got a registrar there with you. What sort of format would it be easiest for you to understand while they're there what's expected? What do you want me to teach them? What do you want them to experience? And what feedback do you want about how they went?
So generally what we do is do an overall assessment. If they're fine, it's only that one where they're not doing fine, I really then go to a checklist of here's some problems they've got. So I think what we do is this is usually a different group of people, the other supervisors say, oh, they're fine, this is what it's not. What's the problem? You get your 3 levels would probably be appropriate.
But do you know what experiences you want the registrars? I mean, I suppose, you're saying you're an RACGP supervisor in a general practice. Is it a general practice? So when you've got an ACRIM registrar come to you, do you know, do you think that, what you need for them to learn is the same as an RACGP registrar, or? Yeah. Hmm.
So you've got your very brief document that just says pre-anaesthetic assessment, but it's a link through it.
Yeah.
If you press the link on the simple words, you'll go to the deeper, semi-deeper screen.
Yes.
That gives you that, and then a further link to further options of that depth. So that with your summary document, you can have that on one screen of your computer or your tablet with the registrar, and go down and say, now, this was the area that I just had a little concern.
Okay.
Let's just press that and we'll go through that, and you can tell me what your experience is, and then you can use it as a counselling tool with them.
Thank you. Dale?
a plea from someone who's very visual and not very wordy. You know, I think when the curriculum's very wordy and it's 120 pages long, it's hard to sort of get a quick sense of what this is about. And I think some curriculums do a really nice job of having some sort of visual presentation that allows you to have a sort of glance at the sort of higher level, and then if it's well done, it's sort of profound. You know, you can look at it and see the simple things, but then you can sort of gaze in and sort of drill down. I mean, that's easier for me to say than it is for you to do, but I think sometimes a visual representation can really help people to get that sort of global type of context stuff that then makes the granularity make more sense. So a plea from a visual person rather than a word person.
Colours are good, yeah. Yeah, yeah.
I just wanted to make a comment on how you're expecting each part to be achieved. I think certainly it's really important to be guiding registrars in terms of you're expected to learn this yourself, like this is self-directed learning type stuff. I worry about being too prescriptive in how the other segments would be delivered because you potentially then lose the richness of, I've seen this particular patient and this was the challenge, and how do we talk about that and what does that bring in, where, if you're saying, that there's only a limited number of hours that training can provide, and you don't want to lose the richness of primary care and the variability that comes into it because you've got to follow something that's more prescriptive. So I just wanted to identify a risk in terms of the being prescriptive about where different parts of the curriculum, in terms of how they will be delivered, because I think that the benefit is that there can be a lot of diversity in that. That there's actually a lot of gains that come from that.
And I don't think the aim is not to be prescriptive. The idea is to be providing guidance. I suppose the medical educators and Emily might like to talk about it. And I know all training organisations do the same thing. You go through the curriculum and you try and work out, do I put this in a workshop? Do I, how do I do this? And which are the important things to cover. And I know from going around and seeing training organisations for accreditation, you're trying to map to curricula and and I suppose so the idea of this was to try and give a bit more of the ACRRM idea of what we would like to see at a high level, certainly not at the detail level. So it's certainly not designed to be prescriptive. And obviously you probably take it to, you do take it to a high level yourselves. You work it out and you say, oh, okay, well, I'm going to put this here and that there. So it was just trying to give some sort of guidance from the curriculum around that. Otherwise, everyone has to interpret that. Any other comments? Yes, Maxine, up the back.
Finished. We had a rule called 1325, and 25 was actually the document contained most of the findings of the research. 3 pages, this is the pages you put out, 3 pages was for people who are quite interested, and the 1 page was for politicians. And so, I don't want to deride the politicians, but we often are in a 1-page place where we only have time to read the 1 page. So maybe a structure where there's a brief and a slightly more detailed, and then the comprehensive might work with the links that the lady down the front was suggesting. Maybe when you think of how much one poor soul can take in, when in a limited time space. So, yeah.
So I think that, that is the concept. So you sort of just get it at the level that you need it. All right. I don't think I really had much more to say. I'll just go through and see. Yeah, I think it's time for lunch. Well, thank you. It was really good feedback, and I'll be able to take that and continue working on it. And as I say, next year we'll come out more formally and consult And if anyone wants to work on the progression document, I'd be very keen to hear from you.
Lynn, this is a very quick and sort of trivial comment. I like the idea of a search function that somebody else brought up. Can I ask, if we do that, can we make it capable of searching on more than one term at a time? So nausea and infant rather than nausea in palliative care. That sort of idea.
I have to talk to the technical people about that one.
I know, but I'm putting it out. I've already mentioned it to the technical people on the website, but it makes a huge difference to how much crap you've got to wade through.
Okay, look, thank you, everybody.